Yasmindi.
Yes.
Now streaming on YouTube. Okay, you may start now.
A very good afternoon to all of you. Today we are going to present a national webinar on COVID and Sustainable Development Goals in the Indian perspective. Department of Geography, Magrahat College. I place my heart gratitude, respected Principal Dr. Ashish Mukhopadhyay, Magrahat College. His wonderful and valuable guidance throughout this our webinar. I would like to thank our Honorable President Haidar Ali Mullik, GB Magrahat College. I would like to express my deep gratitude to respected resource persons, different University of West Bengal, as well as India. I would like to thank our IQAC coordinator, Mondira Sarkar, her endeavor to enrich our webinar. I am also grateful non-teaching and teaching staff of our college. I would like to thank our excellent students and students from other colleges and universities, research scholars, are various universities, participants from various pockets of India. We are so glad a huge number of participants has joined to our webinar in different pockets of West Bengal, India. Respected Principal Dr. Ashish Mukhopadhyay, he has unable to join with us due to sudden illness, but his whole support and good wishes could make a success our webinar. Honorable President Haidar Ali Mullik, he has unable to join with us due to his busy schedule, but he has forwarded and good message our webinar. Today our national webinar on COVID and Sustainable Development Goals in the Indian perspective. Brundtland Commission developed the most widely used definition of sustainable development which meets the needs of current generation without compromising the ability of future generations to meet their own needs. The Sustainable Development Goals, also known as Global Goals, adopted all United Nations member states in 2015 as a universal call to action to end poverty, protect the planet, and ensure that all people enjoy peace and prosperity by 2030. The 17 Sustainable Development Goals are integrated. That is, they recognize that action in an area will affect outcomes in others, and that development must balance social, economic, and environmental sustainability. Some of the sustainable goals are poverty, zero hunger, good health and well-being, quality education, gender equality, clean water and sanitation, affordable and clean energy, decent work and economic growth. Today, we have three eminent speakers with us, Dr. Lakshmi Narayan Shatpathy, Dr. Bhashoti Das, Dr. Shobhan Ghosh. Now I would like to request to our HOD, Ramdev Noskor to deliver his valuable speech. Please, sir.
Thank you. Thank you, Yasmin. Thank you so much. Ultimately, the time has come. Our college will show a historical moment. Very good afternoon to all of you. I know we all are going through a critical moment. We are physically underlocked and mentally shocked. The situation is worsening day by day. We don't know what is waiting for us in near future. It is an unpredictable and ambiguous situation. In this context, we have got such three resource persons who will clarify the situation vividly and show a concrete way to come off. By the way, I must mention a few words for our college and students. Magrahat College had started its journey from 1996 and blossoming day by day, though it locates at the southeast part of South 24 Parganas. This is the very first time the Department of Geography, Magrahat College, is conducting such an webinar. This is why we, the faculties and the students of the departments of geography, are longing for it. If I say about our students, it will be an historical project. Most of them are first generation learner. Not only that, poverty is the nearest friend in their daily life. No, I'll not lengthen my speech anymore. I must come back in the main session right now. Now, I would like to request respected Madam Mondira Sarkar, coordinator of IQAC, Magrahat College, for welcome address. Madam, over to you. Madam, Mondira Madam.
Hello, yes.
Are you getting
Thank
me?
you. Thank
Okay.
you, Professor Ramdev Noshkar.
Welcome.
Indeed, we are not going through the best of times, but as every cloud has a silver lining, academic exchanges over digital platform has offered us a magnificent opportunity to quench our intellectual thirst. Today is certainly a big day in the journey of Magrahat College. At the behest of the Department of Geography, we are holding a national webinar on COVID and sustainable development goals in the Indian perspective. It is a great honor that we have among us Professor Lakshmi Narayan Shatpati, Professor, Department of Geography, Calcutta University, and presently Director, UGC Human Resource Development Center under the University of Calcutta. Sir, I cannot resist the temptation of recalling that day in March 2019 when we were graced by your august presence in our college and treated to an extremely captivating presentation. It is my privilege to welcome you, sir. Today, we are also graced with the presence of Dr. Bhashoti Das, Associate Professor, Department of Geography, Jawaharlal Nehru University, New Delhi. On behalf of Magrahat College, it is my honor to heartily welcome you, Madam Dr. Bhashoti Das. We are also privileged to have among us Dr. Shobhan Ghosh, Associate Professor of Geography, Diamond Harbour Women's University. On behalf of Magrahat College, it is my privilege to welcome Dr. Shobhan Ghosh. It also gives me immense pleasure to welcome all participants who are attending the webinar. Looking forward to a very exciting session, I request Professor Ramdev Noshkar to take over for the rest of the proceedings.
Thank you. Thank you so much, ma'am. Thank you so much, Mondira Sarkar, for your very active cooperation and also delivering a fantastic, I could say, forming welcome address. Here, I have two announcements. Already one announcement have been given by Yasmin Madam, or convener of this today's webinar. Due to an unavoidable causes, our respected principal and honorable president will not attend today's webinar. Under these circumstances, we have to continue the program. And second announcement there, the participants can make the question during presentation on chat box. We'll try to take the maximum number of questions, but question answer session will not be more than 5 minutes. Okay, I'll come back to the main session. And now I'll call my sister colleague Yasmin to introduce our first speaker. Yasmin, over to you.
Thank you, sir. Before we have started technical session, I would like to say for participants, we will provide feedback link of third session. Participants who are fill up registrations and feedback form, they will get e-certificate. Thank you. Now we are introduced to our technical sessions. Resource person and keynote speaker, Dr. Lakshmi Narayan Shatpathy. We are grateful because in spite of his busy schedule, he has kindly denoted his precious time of our webinar. Presently, Dr. Shatpathy in the post of Professor, Department of Geography and Director, UGC Human Resource Development Center, University of Calcutta, West Bengal, India. He has joined of Calcutta University 2006 as a lecturer. Before that, he had started in career as a lecturer in Lal Baba College in the year 1999. He has been awarded MSc and PhD in Geography from University of Calcutta. His area of interest, climate, water resources, geoforms, population, environment and development, curriculum development and capacity building in geography. 12 research scholars have been awarded in their PhD degree. 2 scholars submitted of the thesis and completed 1 postdoctoral fellow scholar under this supervision. And 5 research scholars and 1 postdoctoral fellow scholar are presently guided by him. He has completed 3 UGC minor research projects in as a co-investigator. Many publications published in leading journal of Geographical Review of India and Springer, respectively. Dr. Shatpathy wrote more than 5 chapters in different books and attended many national and international seminars and conferences. He has published several 30 articles, have been published popular magazines, edited books, monographs, newspapers, etc. and edited a book entitled Climate and Society, A Contemporary Perspective, published by Department of Geography, University of Calcutta in the year 2016, which became most popular throughout India. His books are enriched not only our students, but the teachers too in several years. He has attended more than 45 invited lectures delivered in regional, national, and international seminars, conference, workshops, and faculty development organized by various colleges, university, and higher education institutions. Dr. Shatpathy sir has attained, chaired and co-chaired an external member more than a dozen technical sessions and national and international conferences. Actually, it is not possible of us of glorious career in the short time frame. He is a renowned and eminent personality in geographical field. Today his topic delivered is challenges to human resource development under COVID-19 new normal, the Indian perspective. Please, sir.
Thank you, Yasmin. Am I audible?
Yes, sir.
Okay. So thank you, Yasmin. Thank you, Ramdev. I'm very much thankful to the
Welcome,
Honorable
sir. Welcome.
Principal, Dr. Ashish Mukhopadhyay, and the President of the governing body, faculty members, the non-teaching staffs of Magrahat College. Very good afternoon to all of you, the participants, and my very under this COVID pandemic scenario and in future. So whatever the COVID current COVID situation and also in the post-COVID situation, so how our human resource development will take place, that we are going to have a review and forward-looking something we are going to discuss. So, if you tell that what is the best resource or the most valuable resource to us, it is not land, neither water or air or forest or wildlife. It is the human life or human resource. So, many of the Bengali poets in earlier days they used to write or sing that of Jamin, human beings are most fertile areas for production and reproduction of culture and civilization. So human resources are key to any development, but very often in the name of development, we forget about the development of human resources. And for human resource development, it is a very term that requires not only education but also healthcare, sanitation, and their various types of support systems to so a dignified human life can be achieved and a global partnership can be developed through peace and harmony. So if you go through the sustainable development goals from goal 1 to goal 17, it starts with alleviation of poverty and ends with the global partnership, the spirituality. So all these ranges from the poverty alleviation to this global partnership through peace and prosperity that requires a concerted effort and that should be taken by not only by the global leadership but also the local leaderships so that we can live in a better way that our forefathers used to live earlier. But I don't find anything that we are living in a better society because there are so many problems, so many issues in the world level, at global level, at various time scales, at various spatial scales also. Now, if you see this new normal, the term new normal was actually coined in the global depression in 2019 when American economy was collapsing.
We are extremely sorry. It's a technical problem actually.
Network issue, props are in. Hello, sir.
Yes, Devarprat, are you saying anything to me?
I think sir, some technical networking problem from LNS sir.
ইলেনিস স্যার আপনি কি শুনতে পাচ্ছেন? হ্যালো, there's some kind of technical problem actually, sir. That's why we are not able to hear you.
Sir, please unmute yourself from your end.
Actually, it is unmuted. Devarprat, there is no problem from my side.
No. Let me connect LNS sir.
Okay, just make a call.
স্যার আপনারা শুনতে পাচ্ছেন নাকি? Within 2 weeks, sir will join us. Okay.
We are extremely sorry. Actually, it's a technical problem. We are not getting our speaker. Within a few seconds, fractions, we'll try to do it normal. Ellen sir, hello. Are you getting my voice, sir?
Ramdev sir, due to poor network system from sir end, he left. But he joined within 2 minutes.
Okay. It's okay. Have you made call him? Have you made any call to him?
Yes.
Okay. Let him come. This is the problem of the technology.
রামদেব স্যার,
Yes.
এলএনএস স্যারের সিস্টেমটা শাট ডাউন হয়ে গেছিল কিছু প্রবলেমের জন্য, স্যার জয়েন করছেন বলে নাকি।
Okay. Just we'll continue. Actually, it is the technological problem. We don't have anything to do, so we have to wait.
Definitely.
Actually, it is very much a bad luck to us. Actually, continuously it was going on, but somehow we didn't get him. So we'll try and we'll try to connect him within a few minutes. So we are extremely sorry for this disruption. Actually, we are extremely sorry. Within a fraction of time, we'll join him, and this program will be continued. So all participants are requested not to be worried. Actually, it is the problem of the technological side. So we don't have anything to do. Our technical assistant, our technical expert is trying to connect him. He's saying only
Okay, sir, connected.
within
Sir,
2 minutes.
connected.
Okay,
Sir, connected. Okay.
Thank you, Devarprat. Thank you so much. But we're not getting him.
Yes.
Just wait.
Extremely sorry because of this technical failure.
Yes.
And this is basically this is a part of the new normal.
So this is the
So
main
new
hindrance of the
normal,
technological side. Okay, okay,
yeah.
sir. We are getting you clearly.
So the new normal concept came through the global depression that started in 2009 and ended 2007 and ended in 2009, but its consequences went on for around 1 decade. And then the global economy that again regained. That time, India was system and a kind of protected economy and all that. So whenever we talk about human resource development, if we don't understand the global and regional perspective, the national perspective, then it will become a futile exercise. Because human resource development is not, cannot be isolated with the our developmental goals in industries, in agriculture, in the job market, and many ways. So whenever we provide a kind of health or education to our social goals and aspirations, and accordingly our social institutions from family to the national governments, like the say the central government or the provincial governments or the parliamentary system, everything is very much linked, and that we should not ignore. Now let us through some of the points of human resources of India. So what are the advantages and disadvantages that we have? Many people say that the 21st century is going to be the century of India, or if it is not India, then the global south. And there, India is going to take a very good leadership role, because in future, India is emerging as a very fast developing economy, and by the year 2030 or 35, it is supposed to be one of the largest economies of the world. And then we can see the dichotomies also. At one point, India has achieved almost number one position in the space administration, in the space science, but at the same time, we have very backward and remote areas, both geographically and also socially. Now, if you see the poverty, then poverty has come down by percentage almost 25 to 30 percentage points since the independence. But if you see the total number of poverty, poor people, then it has not decreased, rather it has increased. And if you compare with the global purchasing power parity, then also you can see that almost 50 to 70% of Indian population, they are poor. And then in terms of education, so if it is the literacy, and literacy becomes education, but definitely literacy and education are not the same. So whenever we say that someone is literate, that means it is not just the capability of signing on something that can, so something that can be understood through a piece of reading, and then in his or her own way that can be expressed in words or in writing, then only we can designate a person to be a literate person. Now, literacy and education are definitely different. Similarly, skills and educations are also different. Now, you see that other parameters also, the child mortality, the maternal mortality, that has drastically come down, definitely, but not as compared to the global north. So India has a skewed development with some of the emerging super riches in our country. They have their names in the Forbes. Same uh, mm, uh, issues, we can find that a large population, they are remaining in the below poverty line. So this skewness of income distribution, thus barriers, access to the social resources and life support systems, This is definitely very, very negative areas of Indian human resource development. Now you see that there is a coincided with the new normal. That means in the new normal, technology is going to take a center stage, and technology means the computer ICT based technologies where data is going to play a significant role in decision making. And data driven, the industrial revolution requires a different set of population that will be able to take some of the computing systems in terms of artificial intelligence, machine learning, and various types of algorithms and all that. But now you can see that the people have to learn computing technology and many other things gap. The economic gap, the social gap, the language gap, and finally the technological gaps. These gaps are increasing, and the country is progressing in terms of development in the total per capita income, total GDP, and total market share in the world. The economic leadership is also coming up, the political leadership is coming up. But at the same time, the marginalization of the population at various sectors and also various societal level, various geographical corners, it is also a very much reality. Now you know that education is very important input to human resource development, and recently government of India has come forward with the new education policy after around 3 decades. And I have gone through it and I have found that the new education policy is basically a kind of Americanization. And that is very much going to promote the market economy, and it is mostly designed to provide a skilled labor force in the market. And here lies the basic question that India has the advantage of demography in terms of demography because we have a very good, vibrant population, and our median age is around 27, 28 years, and it is the year. Now, parts of the world, particularly global north and many other stable, already high economically developed countries, they have but India disadvantage is that the quality of population is very low compared to many other global north countries. So this new education policy has tried to uh, make a skilled labor force through technology-enabled learning system since the early childhood learning to the university and other educational systems. So national skill development framework and like that. So many skilling and reskilling of the population. This is the primary motto. And whatever I have found in the education policy, it's supposed to be very good. It seems to be very good, but the hidden agenda is to industrial revolution. of the education. Very much affected with this global COVID-19 pandemic because the classes are not being held and the infrastructure is not available. Even if you can see that the EduSat and many other programs in the satellite telecommunication system, India is one of the best in the country. And EduSat and many other platforms were developed long before, but we are still not being able to reach to the students at the remotest corners of our country, even in the urban and semi-urban areas also. Most of the students are not being reached by the providers of the education, our formal system. It is not possible. Even in the colleges also, we are not being able to take examinations. So now think of that at one side, we claim, India claims that it has one of the best infrastructure in the ICT. If you see the digital platforms, this digital initiative that started since 2015, but at the same contradiction is there that it is not being accessed by most of the population, around 60 to 70% of the population of India, the students' population of India, they don't have access to this kind of learning resources. So this is a very, very important issue that we have to think about. It is not that in terms of the average income that is the most important, but the skewness of income distribution, the health care and education, that should be taken care of by the government. And it is a question of the governance actually, both at the central level, at the local level. And India boasts of the largest democracy in the world. But in this market economy system that is going through full swing, I don't find that this democracy is somehow being curtailed at various levels. And then we question that who are curtailing? Is it the America is curtailing our democratic rights? No, it is we, the people of our country, because there is a some kind of alluration from the market economy in terms of job and many other consumer satisfactions and many things. So that allures us, and we become slaves of the market economy. And then finally, our education is going to be just skilling. And I don't think that skilling is the right kind of education. That kind of education we require that will promote governance, good governance, the democratic governance that can challenge the governments and the leaderships. So that sort of educations we are lacking, and particularly under this COVID-19 situation, this is very much a difficult scenario that whenever we are locked, we cannot protest. So under this scenario, definitely we are going through a severe crisis in our human resource development. So with these words, thank you for allowing me to join and rejoin in this platform. Thank you very much.
Thank you.
So
Thank
if
you
there
so
is any
much, sir.
question, I'm ready to take.
Sorry, sir. Okay, sir. We'll try to take us a few questions. Thank you so much, sir, Dr. Lokhinarayan Satpathy, sir, for your very enriching and very informative speech. Not only that, you have mentioned so many sides of the human resource, and also you have mentioned so many education systems and health systems, and so elaborately you have described about the subject. And I'll wait for 5 minutes or for a while for the question. If there is any question, I would like to request our participants to make the question through their chat box. Actually, some problem has come because we didn't get the share continuously. Some kind of the technological issue or the technical issue or the network issue has been occurred. That's why we didn't get him. So we are extremely sorry for that. But now We are waiting for the question from the side of the participant.
Yes, if it is in the chat, so I can answer. Because I can see the
Somehow
chat
we are
box.
not getting you continuously, sir. I don't know from which side it is problem.
Yes.
This problem is going on, but it is to happen, sir.
Okay.
But I think there is no
This is a
question.
technological hazard.
It is true, sir. It is true.
Okay, so if there is okay, so
If there is any
thank you
question,
very
then
much.
I'll if there is any
Okay,
question, then I'll contact you and I'll
yes,
try to
I'm also
contact
here.
you.
I'm going to listen to Bhashoti Di also. Okay.
Okay,
So I'll be there.
That
No
means you will
problem.
be there.
Okay.
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 So
Yes.
I'll come
Okay.
back.
I'm here. Yes.
Now,
If there is any question, I am going to see. Yes.
Okay, sir. Okay. As you are with us, that's why we can take you anytime. Any question we can take anytime. So we are just proceeding our program, and now I would like to go our colleague Yasmin to introduce our second speaker. Yasmin, are you getting me?
Thank you, sir.
Okay.
Now we are moving our second speakers, Dr. Bhashoti Das. Brief introduction about speaker. Bhashoti Das is faculty in population studies at Jawaharlal Nehru University, New Delhi, India. Her area of interest includes study of population in the context of development. Before joining to academic, she worked as a research consultant in international agencies like UNICEF, UNWFP, and UN Women. She has so far more than 30 publications published in leading journals on population and development issues. She has published 1 edited and 2 authored books so far from Rawat and Spinjar publications respectively. Research areas. Dr. Bhashoti's focus of interest is in population and development with a major thrust on demographic behavior in different development regions. Her researchers have thrust on poverty, well-being, migration, and gender. So far, 21 students have been awarded PhD degrees, out of which 12 have worked specifically on migration issues. Most recently completed project, Gender Atlas of India, sponsored by Department of Science and Technology, DOI. Current ongoing project, major project, consequence of male selective our migration from rural West Bengal, sponsored by ICSSR. Today, her topic delivered is understanding migration in the light of COVID-19. Please, madam.
Hello. I want to share screen. So you have to allow me to share my screen.
Okay, you may share now, ma'am.
Yeah. Is it?
Yes, it is visible to us, madam. You may continue.
Yeah, I'll just take. Okay. Thank you, all the organizers of Magrahat College.
Welcome.
Ramdev and Principal Dr. Ashish Mukherjee, and of course Yasmin, who has contacted me. And it is really interesting to see you that your effort to be in a so-called non-privileged area, you have shown enough enthusiasm to bring some of the issues which we are otherwise discussing here and there in a concrete format. And in this regard, I would like to undertake the issues of migration for the very reason that I work in this area and it's my area of interest. So do I have to mix with Bengali or English will do?
Okay, as you wish, ma'am.
Okay. Okay, let us start. So when we are talking about migrants, I will go to the definition first. Who are the migrants in Indian context? Of course, I will be taking, because the definition varies from country to country, but more centralized is whose place of birth or place of last residence is different than their current place or place of enumeration. They are the migrant in this case. And in Indian context, we get data for both of this kind by birthplace and also by place of last residence. But majorly we concentrate on place of last residence because that is more dynamic, and especially this is for the students. You might have heard about return migration, that many people come back after their retirement to their place of birth. In those cases, if we take the place of birth kind of data, we cannot capture that group as migrants. So place of last residence is more sensitive, and my data will pertain to place of last residence. Second point is how sustainable development goals are related to migration as such. When Yasmin was speaking of the sustainable development goals, and for that matter, all of you might have known by this time, there are 17 goals. And in none of these goals directly migration has been coined or termed. So what are the context in which SDG has been recognized? These are the few lines I have taken directly from the UNDP manual, that they recognize, means these goals recognize that ending poverty and other deprivation must go hand in hand with strategies that improve health and education, reduce inequality, and spur economic growth, all while tackling climate change and working preserve our ocean and forest. For this matter, today we are not considering the climate change and preserving our natural resource at this moment. But it's very well crafted. Of course, I would like to thank the geography department that the speakers they have chosen and the topic the speakers have given are addressing all. We have heard already Professor Satpathy, who has spoken about the education, and following me, who will be talking about the health access. Now, what is remaining is reduce inequality. While addressing inequality, migration is one indicator which is very precisely actually address or show us the inequality. How? I'm coming to that in next few slides. I have only 2 slides, but several explanations. Now, why this is coming again and again, 2 people entered. Migrants by reasons for migration. Of course, we do not have very fluid data for migrants, for that matter, any of the population characteristics, and we rely mostly on Census of India, and we are left with only 2011 census data. But what I assume that between 2011 to 2021 census or 2020 when the COVID is going on, the number of migrants might have changed, but there are very bleak chance of change in their proportion. The share, the way in the pie graph is showing, that proportional change, major shift in that proportional change is rare. So we can assume that this pattern was continuing in 2019 and 20 beginning, end of 2019, 20 beginning. So major part of our migrant, of course, I think even the students know by this time that it is the marriage migration because of our social cultural reason. Moved after birth is also a kind of social cultural reason. Moved with household is mostly when one of the spouse goes or the son goes and then they bring their parents, this kind of movement, or move with household. Education and business are very clear. Others are natural calamity or social disturbance, political ostracization, anything of that kind which is not covered otherwise. And oh my God, my slide is showing work and employment in faraway place. So work and employment, that is 9%, which is the most affected during the COVID-19. Now, you already, all of us have experienced, and it was very bitter experience, and it is with pain we had to experience the plight of the migrants, but they are only 9%. But even if it is 9%, 9% is no less, because what is the size of the total migrants in India by place of last residence? When we take the total population, it is 456 million. 456 million. So 9% of that is also huge. And when I am talking that nearly half are marriage migration, they are of course the females. So we get 310 million are female migrants out of that. So males are only 146 million. That 146 is not a only figure for India. So they are the group who actually, out of this 146, this 9% who are work and employment, they were worst affected. Now the question is all of them worst affected, or there are the categories of vulnerability? When we look at this, we must try to see, first we segregate this 9%, because this presentation I made it exactly looking at the undergraduate students, that understanding data is very essential for you to understand any of the facts. A newspaper or Facebook or WhatsApp, we have started terming it as university also. So WhatsApp university, all those, the kind of data it churns, you should open up your mind to understand how much truth is there and whether you can extract truth differently from that. So now we will concentrate on this 9%. When we are going by migrants by duration of stay, you will be surprised to see that more than 50% of the migrants are actually older than 10 years and above. That means they are, we can expect, like me, I am a migrant in Delhi, we are relatively settled. For that matter, it is not only me, more than 90% of JNU is actually migrant. Except the students, all the teachers are relatively settled in this university. All the staffs are relatively settled in this city. So they are not vulnerable. Now, who could be most vulnerable within this? The worker who have reached in last 1 year, or for that matter, one can consider even the last 5 years, who are still either struggling to establish themselves or searching a better job or established themselves in some kind of fragile job. Fragile job means where they can be fired at any point of time, or any kind of shock they are unable to absorb. So this is the only the proportion who are most vulnerable. Now, if you see the Indian census data, migration tables, uh, which is showing that among the worker, those 9% who are for reasons of work who have come, among them, all have not got job, or all have not been absorbed in the market economy. There are around 30 to 35 lakhs of population who are still searching job. Then you may ask, then how they are surviving in these metro cities? They are surviving through some petty jobs, which are most vulnerable again under any kind of shock. Forget about COVID. It is also vulnerable for any kind of riots. It is vulnerable for any kind of flood. It is vulnerable for any kind of drought. They are vulnerable to any minimum shock. COVID is a big shock. It is a very big shock. It rarely comes. But those are the shocks which are quite regular in any kind of, any countries. I will not blame only India. Any countries are vulnerable to those kind of shocks. So these 30-35 lakhs are very vulnerable population. This is, I am talking about 2011 census. And we definitely assume this will remain more or less same up to 2019-20. Also, there could be marginal rise, there could be marginal decline. But more or less, it will remain a very large number. More or less, it is a very large number. So, this is the most vulnerable population. When we are talking about this 30-35 lakhs who are not having jobs or have very petty job and still searching job, where could they be living? You start think, where could they be living? They are living in the slum areas. And you are a student of geography, you already know that first generation migrants, most of the theories say that those who are, especially the rural to urban migration and unskilled or semi-skilled or semi-literate migration, are mostly reaching to the slum areas for their initial settlement. And slums, by definition, are the most congested areas. So, any kind of breakout of this kind of contiguous disease or infectious disease make them more vulnerable. First, they do not have income. Second, they are more vulnerable to the infection and other kind of disease. Third thing is that what is slum? It is not only congestion, they also lack access to the basic amenities, water, sanitation. Now, when we were popularizing washing your hand, washing your clothes after coming back from the market, washing your shoes. So in a small room, there are 15 laborers are living, and there is nothing called outside the room where they can live there, even the sandals. There is common tap, common toilet, common bathroom. So cleanliness, maintaining this kind of cleanliness is a big luxury. So evacuation of the slum was an essential strategy to tackle with the COVID-19 kind of infection. And in fact, though we do not have any official statement, many people, all of you know that Dharavi is the Asia's largest slum. So whenever we talk this, it's a kind of sense of pride comes that as if slum is also good. Anything large is good, Everest is good, so slum is also good. So everyone is referring Dharavi is infected. Dharavi is largest slum in the world. My question is then what we were doing? We were taking pride to make it or remain it the largest slum of Asia? Or have we ever tried to address any of their issues? We have thousands of urban planners, we have thousands of documents, vision document 2020, 2030, 2040, everything, but slum remains slum. Slum remains slum. COVID is actually eye-opener to us that who are paying the cost. And in fact, it is painful to say, but it is the truth that Dharavi has almost become evacuated. You might have also have heard that hardly any people are still staying there. And Mumbai as such has contained its infection, whereas other districts are still having the infection. So that is another lesson. I am talking entirely with this 30, 35 or 9%. Just a moment. If it is Radhesham, I am not going to come now. Okay. My Mali has come. Okay. Chalo, continue. Now, I will come to the how migrants are associated. This is some data I have said. The third thing what I am trying to say is reduce inequality. This is the group which requires to be addressed through sustainable development goal if you really have to reduce the inequality. Every skyscraper has a slum behind it to serve themselves. That is the neoclassical model of migration. And almost all the third world cities have this kind of slum development. It is not only in India, across the third world countries and especially the colonized countries, the way the history of their urbanization has developed, it has become inevitable for them to develop the slum. So this inequality needs to be addressed. How this inequality has emerged, that is also very interesting to see. If we take that early 90s onward, when the globalization has happened, it was inevitable. There was no other option for us than to open up our economy, because all of us know that during that time we had only 9 days resource available. So only 9 days country could have fed its population and run its production. When the then Prime Minister, then Finance Minister Manmohan Singh has opened up our economy. And when we see this in that race, many of the states have joined that race, and of course has developed some of the zones of economic development. And in that context, if you see the districts, concentration of the 270 districts, I didn't give the map here, concentration of the 270 districts, out of 270, almost 200 districts are, you can put northwest to southeast line, where Gujarat, Maharashtra, Karnataka, Goa, Tamil Nadu, Andhra Pradesh, not Telangana, and part of Madhya Pradesh have almost 200 of the districts. Rest 70 are few are in Odisha, 1 in West Bengal, 2 are in Uttar Pradesh. It's such a large state, you have only 2. The SEZ, Special Economic Zone, where the economic activities started developing. And so what we have seen that slowly the opportunities for the eastern region has dried up, and also the northern region. Neither Bihar nor UP has come up in this. What part of UP is developing? It is only Noida, which is getting the locational advantage of Delhi, the capital city. Capital city always have certain kind of advantages. So it is getting that advantage, so it is developing. No other city than Lucknow has even one SEZ or for that matter, any economic zone. In case of West Bengal, we have only Falta as the special economic zone. So labor remained without work, work opportunity reduced drastically since 90s, and they had to come out. They had to come out. Where they will come? They will come to the slums. Why? Now, again, I will relate to Professor Satpathy's lecture that we have very vibrant size of population. Quantity is very vibrant, very huge, but quality-wise, we are really poor. All the state ministers, when they are, I am closely following and listening most of the ministers' speeches, especially those who have got them back, Bihar, West Bengal, UP, where all the prime ministers, all the chief ministers are accepting that majority of them are unskilled. What they were doing reaching at Mumbai, Surat, or Ahmedabad, they are unskilled. And that means they were exploited severely by the employer, whatever way, because they lack the bargain power. Until and unless some kind of, I agree with Professor Satpathy that skill is not everything. Wisdom also is required. So skill and wisdom, where to go, how to handle your skill, and how to come out from the exploitation, everything is lacking for this huge group of population. When they become, it shows that it becomes a liability exactly in this case. And also we are observing over the last few months, 1 or 2 months, that those who are extremely skilled, they are being called by their employer. I take the case study of one of Delhi's famous mushroom cultivator, where he has flown his all 16 laborer to Bihar, Samastipur, and again he has paid them airfare to bring them back, where he is saying that September to December is the cultivation time, and they are already skilled, and I do not want to lose them to train some other people, some other from the Delhi to train them. I need them only to get the profit and the loss what I have made during this season. So this is the important thing. If the skill is there, the demand is there, but we lack skill. So with this, I think I have given some highlights only and tried to relate it with sustainable development goal. And I'll be very happy to discuss with the students if they have any observation. Thank you.
Thank you. Thank you so much, ma'am. Thank you. Thank you, Dr. Bhashoti Das, for your relevant and very enriching presentation. And we have got a very clear information and idea about your topic from your topic. And also thank you so much for your ma'am. You have shared your valuable view with us. Thank you so much. We'll wait for a while. If there is any question, then sure. I'll come to you, ma'am.
Sure. We can go for the third presentation, and we can take all the questions afterward also. If they need some more time to think, because they need some time to digest the information.
Yes, ma'am. If I get any question now, then I will come to you. Otherwise, I will continue for the third speaker.
Yes,
okay.
Sure.
I think our participants will make the question after completion of the all speakers presentation.
Sure.
Okay, I will continue, and I definitely I'll come to my sister colleague Yasmin madam for addressing our third speaker. Yasmin, are you getting me? Yasmin, Hello. Yasmin.
Thank you, sir. Thank you, madam.
Yes, welcome.
Now we are moving into next and last speaker, Dr. Shobhan Ghosh. Dr. Ghosh, an associate professor in the Department of Geography, Diamond Harbour Women's University, South 24 Parganas, West Bengal. He has completed MA and PhD in Geography from the University of Burdwan, West Bengal. He has secured first position in both undergraduation and post-graduation level. He served as an assistant professor for more than 10 years at Ramananda Centenary College, Purulia, and West Bengal. His area of interest lies in human geography, environmental issues, education and geography, regional planning, backward region development, urban planning. He has completed UGC research project. He has more than 30 national and international papers, written 5 chapters in different books, and had attended 45 national and international conferences and seminars. He has keen interest on multivariate analysis using SPSS, AMOS, and got training on that in several workshops. He is associated with several professional bodies like Indian Geographical Foundation, Kolkata, Indian Institute of Geographers, University of Pune, Maharashtra, Associations of Population Geographers of India, Punjab University, Punjab, National Association of Geographers, India. He has awarded Best Paper Presenter in International Conference on Urban Development organized by Institute for Social Development and Research, Ranchi, in 2018, India. He performed his duty as coordinator, NAC Steering Committee, Ramananda Centenary College, Purulia, and nodal officer for AISHE from 2012 to 2017. Currently, he is supervising 5 research scholars on issues in human geography, like problems to access to healthcare facilities of women, urbanization, technology and quality of life, cyber culture, and language dynamics. Today, his topic delivered is hurdles of access to healthcare services of women in rural areas of South 24 Parganas district, West Bengal. Please, sir.
Thank you, Yasmin. Am I audible to you and everyone?
Yes, sir. Yes.
Okay,
yes.
okay. So I am
Yes,
just
yes.
first of all sharing my screen. Then I'll go, after that, I'll go for my deliberation.
Okay, sir.
So it is visible to everyone?
Yes, sir. It is very clear view we are getting.
Okay, okay. Thank you. Thank you.
Welcome.
At the very outset, I would like to express my, At the very outset, I would like to express my heartfelt gratitude to the respected principal, sir, Magrahat College, Dr. Ashish Mukherjee, for giving me the opportunity to be a part of the national webinar on COVID-19 and Sustainable Development Goals in the Indian perspective, organized by the Department of Geography in collaboration with the IQAC of that college. I am especially thankful to the convener of this webinar, Yasmin Khatun, and organizing secretary, the HOD of the department, Dr. Ramdev Noskar, and of course, the IPSC coordinator, ma'am, for their wholehearted effort. I would like to thank the other resource persons assembled here, the participants from various corners, the students, researchers, research scholars, and beloved audience to make this webinar a grand success.
I'm interrupting you, sir. One more.
Yeah.
1 minute, sir. So you have mentioned the Dr. Ramdev. I'm not doctor, sir. That's why.
Oh, okay. You would be Dr.
Okay.
So, okay.
No, sir.
Sorry,
Thank you, sir.
Sorry.
Okay, sir.
Okay. So, at the very first outset, I will just come to my topic. Today, I want to share the hurdles of access to healthcare services of women in rural areas of South 24 Parganas district of West Bengal. In this global pandemic situation that we are passing through, it is important to realize that the pandemic of COVID-19 has initially happened in well-developed countries that have achieved the so-called health transition. However, the virus does not differentiate between rich or poor, rural, urban dichotomy. It is particularly a threat to a country like India, where 65 to 68% of the population lived in rural areas, that also has the highest overall burden of disease globally. Indian rural healthcare system, as we know, is a three-tier system that comprises sub-centers, primary health centers, and community health centers. Now, first of all, I will come to the shortfall in the present juncture. The shortfall in the health facilities, as per the Statistical Division report, Ministry of Health and Family Welfare in 2018, that already we have 18% shortfall at sub-center level, 22% shortfall at primary healthcare level, and 30% shortfall in community health care level. The workforce availability is also substantially below the recommended level as suggested by the Health Organization. Rural India has 3.2 government hospital beds per 10,000 people. Overall, the shortage of specialists is there, that is working at the CHC level, almost 82%. This includes the shortage of surgeons, 85%, gynecologists, 75%, physicians, 86%, and pediatricians, 83%. Despite the National Health Rural Mission and the government's commitment, adequate and appropriate healthcare is still a mirage. And COVID-19 added a special challenge, considering the poor testing services, surveillance system, and above all, poor medical care, including the shortages that have been mentioned earlier. The rural India now at present is facing a chronic shortage of medical professionals, unregistered and untrained staff in caring and handling patients during an outbreak of infectious disease. Against this backdrop, certain question haunts to our mind, that what are the hurdles of healthcare services to women in rural areas in India? Is it the remote location, or the availability of the healthcare infrastructure, or the availability of the healthcare providers, service providers, or the affordability for the utilization of the healthcare services, or the socioeconomic condition, the cultural mosaic, or we can say it as the social acceptability of the healthcare facilities, or the present scenario. So, true to fact that for some, access to health service is difficult. Economic affordability poses hurdles to many, whereas cultural barriers or families' traditional norms are a setback to the health service of women. Even though the health service provider or the geographical access is improved, local women cannot use the service unless the provided service meet their demands in quality and quantity matters and cultural manners. And what is important in Indian scenario, Indian rural scenario, is that in the healthcare scenario of West Bengal, particularly, the healthcare services are disseminated in a few numbers where most of the people live. It is hardly adequate. And another important point, that access to healthcare service and the quality of care administered at all levels of health care have been considered as the central determinants of health outcome. Access has been described in terms of both the characteristics of the healthcare system and the characteristics of the population. As we have found that health system has become more complicated, so the hurdles of access has become more complicated also. It takes into account 4 A dimensions. The hurdles with regard to access accounts for 4 main dimensions, 4 A dimensions. What are the 4A dimensions? The first A is the geographical accessibility. That means the accessibility problems regarding connectivity, accessibility, and distance. The second A is the availability of the healthcare service, which is also called supply side determinants. That means whether the primary, secondary, and tertiary services are there. I'll come to later this point. Next is the affordability of the healthcare service. Affordability of the healthcare service incorporates the distance, time, and out-of-pocket expenditure. And the fourth one is the acceptability of the healthcare service providers and the receivers, which is also determined by the family tradition and family culture. Now, my point of submission is that these 4A dimensions paralyzes all the efforts of universal and quality healthcare. Now, how? First of all, come to the point of first A, that is geographical accessibility. Geographical access is the distance needed in order to reach a health facility is not only a direct physical barrier that precludes women from reaching health institutions, but it also affects even their decision to look for care. There are three kinds of delay that are associated with this geographical accessibility. Delay number one is the delay in deciding to seek care. It occurs due to lack of understanding of the danger sign. Delay 2 relates to the delay in reaching an adequate health facility. Here comes the point of transportation facilities, the point of distance, connectivity, and accessibility, and of course, the cost of the travel. Delay 3 relates to the delay in receiving adequate care or on that facility. The proximity to health services exerts a dual influence on healthcare utilization. Long distances can be an obstacle to reaching a health facility, as well as disincentive to even try to seek care. The non-availability of reliable means of transportation also deteriorates the situation. Geographical accessibility, as we know, is one of the factors that can influence the timely, quote and unquote, timely use. That's very important. Another alternative school of thought that suggests that the role of geographical accessibility hindering healthcare service or access differs as per the perceived health needs of the population. Therefore, a higher perceived need is often seen to overcome the influence of geographical accessibility. Now come to the second A dimension of access. Another important hurdle is the availability that I've already mentioned. The availability is with regard to primary healthcare. That is, the primary care level is the first level of contact of individuals, the family, and the community with the national health system. Sub-center, primary health center are included in the primary level of care. Secondary level of care is generally provided by district hospital and community health centers, which also serve as the first level of referral unit. The tertiary level is a more specialized one than the secondary care level. This care is provided by the regional or the central level institutions like the medical college and hospital, all-India institutes, regional hospitals, specialized hospitals, multi-specialty hospitals, etc. In Indian rural healthcare scenario, the sub-center is the most peripheral and the first contact point between the primary healthcare system and the community. The third A dimension of access coincides with the affordability dimensions or the financial access. Besides the direct cost of treatment and informal payments, there are also indirect costs that deter the poor from seeking treatment. Affordability reflects the payments made by the service users, including various types of out-of-pocket expenditure, but also indirect payments also that makes care less affordable and limit to it. Financial barriers means that even if care is available and appropriate, the childbearing woman might be unable to access because she cannot pay for it. Financial barriers that influence health and healthcare in a number of ways, that is income loss or threat of dismissal, can result in reduced willingness to take time off from work to access healthcare. So the three dimensions are distance, time, and out-of-pocket expenditures that encompasses the affordability dimension. The fourth dimension of A or hurdle is the acceptability, that is a social acceptability. Acceptability is determined by the cultural, traditional, and literary factors that determine whether institutionalized care is accepted by individuals as well as how often care will be demanding. Thus, care might be available appropriate, affordable, and approachable, but not acceptable due to cultural, traditional, and health literary aspects in determining the need for institutionalized care. A lack of healthcare providers from culturally diverse groups further limits the incorporation of cultural understanding into available healthcare services. Social acceptability also plays a significant role for low wage of government facility and high preference for the rural medical practitioners. The My study concentrates on the South 24 Pargana district, and I want to highlight at the first of all from the district level and next come to a block level analysis how far these hurdles of 4A determines the access and success of healthcare facilities of women in rural areas of West Bengal. The study area is known as South 24 Pargana district, and it has been found that the South 24 Pargana district was undivided prior to 1986. The district is situated in the extreme southern parts of the West Bengal. It possesses 5 subdivisions, 7 municipalities, 29 blocks, and 312 gram panchayats. 71% of female literacy is there, and 74.42% population live in the rural areas. Insofar as the healthcare facilities is concerned, it has been found that particularly the marriage and fertility, and of course the delivery care, which is associated with the female healthcare particularly, it has been found from the report of National Family Health Survey that women aged 20 to 24 years married before age reaching 18 years accounts for 54%. Maternity, insofar as the maternity care is concerned, it has been found that mothers who had full antenatal care is only 13%. Mothers who receive postnatal care from doctors, nurse, and other health personnel within 2 days of delivery is 49%. Children born at home who are taken to a health facility for checkup within 24 hours of birth only amounts to 6%. And insofar as the delivery care is concerned, it is important that institutional birth accounts for almost 47%. And home delivery is almost close to 16%. And what is important is that this district has doctor population ratio more than 1:10,000, bed population ratio more than 1:2,000, medical institution population ratio more than 1:28,000, and primary healthcare center population ratio is more than 1:90%. So what is important here, these 4 dimensions have been coagulated into a healthcare infrastructural three main issues pertaining to healthcare facilities. Number 1, availability of the healthcare infrastructure. Number 2, performance of public healthcare services. And number 3, accessibility of healthcare services. In these 3 broad parameters, 17 parameters have been taken into account, and see the result on the availability dimension of healthcare services. It has been found that 18% blocks of this district also show very disappointing performances, for 1 doctor is there to serve 25,000 to 50,000 people. In 11 blocks out of 29 blocks, 1 primary healthcare has to serve more than 1 lakh population. The national norm spoke of 1 primary healthcare center for every 30,000 people. It is unfortunate to note that out of 29 blocks, in 17 blocks, 1 sub-center is there to serve more than 5,000 population. And insofar as the performances and accessibility of healthcare findings is concerned, it has been found that home deliveries are still preferred through DIMAs or rural medical practitioners in certain blocks like Canning and other deltatic blocks. The clinical attendance of patient has been analyzed in terms of indoor and outdoor patient to total care. The picture is very grim in deltatic blocks and the peripheral blocks. About 59% blocks have less than 5 medical institutions per 100 square kilometer. Canning 1 block secures the lowest position in terms of primary healthcare center per 100 square kilometer. Insofar as the percentage of villages within the nearest primary health center is concerned, within 5 kilometer radius, the picture is very grim and alarming. From the healthcare infrastructure map, index map, it has been found that less than 7% blocks of the district show high level of healthcare infrastructure, and 16 blocks out of 29 blocks are moderately developed insofar as the healthcare facilities are concerned. And poor performance of these health indicators are due to the indicators or the poor result of the indicators that have been mentioned earlier. the descriptive statistic analysis shows that population per medical institutions and population per medical officer are bearing higher mean values. Frustrating picture is seen in case of female literacy rate, and the mean value of bed per population and the higher standard deviation value reveals that the bed in hospitals are unequally distributed and widely varied on the population. The principal component analysis shows that in PC1, doctor per population, bed per population, clinical attendance positively run the system with the high loading. Medical officers and medical institutions need more improvement. In PC2, what is found that population per medical institutions and home deliveries with clinical attendance, it positively run the system with high loading, and female literacy here comes an immediate area of concern. In PC3 and PC4, the number of villages near primary healthcare center, that is the supply side determinants, are found to occur. Now, from the Prince score, that is from the principal component score and jet score mapping, what is found that close to 45% area falls under the moderate developed area. Less developed area comprises 31% of the blocks. The blocks are Canning 1, Canning 2, Goshaba, Bhashoti, Magrahat 2, Joynagar 2, Bhangar 2, Kultoli and Muthurapur. The analysis reckons that some blocks are in transitions or at the zones of interface between two regions of better health facility status. On the other hand, Bhashoti, Goshaba, Magrahat 2, Canning 1 are located far from the axis, defining that these blocks are in poorest health conditions. Now, from this macro analysis at the district level, now I am coming to a micro analysis at the block level. Here, Canning 1 has been taken as a case study. And what is found that Canning 1, see how the Canning 1 has been taken as a case study. Canning 1 block comprises 10 gram panchayats, 71% total literacy rate, whereas the female literacy rate accounts for only 44%, and the block considers 56 sub-centers and 1 rural hospital. Now, the hurdle number 1, that is the geographical accessibility. See how the geographical accessibility paralyzes the good health outcome and quality health for the rural women in Canning 1. See the connectivity pattern of this area. The connectivity pattern of this area reckons that the beta index value is low as 40% GPs, is moderate at 50% GPs. That means 90% GPs almost have very low beta index values. Insofar as the aggregate transportation score is concerned, it has been found that the lower value of the ATA score are the result of a fewer number of nodes that itself is a function of terrain handicaps, improper allocation of resources, and regional imbalances. And the road density map also depicts the paucity of metal load of the block under scrutiny. And insofar as the metal load buffer map and unmetal load buffer map is concerned, it has been found that out of 61 inhabited village in Canning 1, 11 villages, that is 20% village, can access to metal load within 2 kilometers of their village periphery. The block suffers from tremendous paucity of transport network. Out of 61 inhabited village, 25 villages, that is 41% village, can access unmetal load within 1 kilometer from the village center. Most of the villages are connected through unmetal loads. The unmetal loads are insufficiently covered all over the block. Now, this is a nodal accessibility zoning, and the nodal accessibility zoning map shows that 10% GPs fall under relatively better accessibility region, and more than 50% GP register moderate accessibility, 30% GPs are located in low accessibility, and also 10% GPs are located in very low accessibility. The very low accessibility in most of the part of the block is due to the dearth of road network, low transport facilities, greater topological distances between nodes, and lack of direct connection between the nodes. Now, another important point which comes with the accessibility pattern is the uptake of care for curative needs and institutional delivery by the women across village parameters. And it has been found that in respect of delivery services, almost 1 of 2 women seeks institutional delivery care in high accessible villages, whereas the number is 1 in every 10 women in low accessible villages. The rate of institutional delivery was higher for the women of accessible village, that is 44%, compared to their counterparts, 11.51% from the village having difficult accessibility. This is the condition that whether the women are asked whether you get all the time the transportation facilities, they say 66%, 60% says they get sometimes. Whether the time spent in healthcare treatment, more than 30% opine that greater than 2 hours. And of course, the condition of the road, particularly in the waterlogging rain season, is very disappointing, particularly waterlogged and mud road conditions. Now, this is the logistic regression that has been done for women's use of institutional delivery in both high and low accessible villages. And it has been found that use of institutional delivery service decline as the distance from the nearest health center becomes longer and longer. Women within 5 kilometers of health facility were almost 5 times more likely to deliver in health facility than those with more than 5 kilometers in the rural area under scrutiny. The present study also showed mothers who had 3 or more ANC visits, antenatal care visits, during their recent pregnancy were more likely to use institutional delivery care than those who had never visited. ANC visits at regular intervals exposed women to more health educational counseling that augmented the potential for seeking institutional delivery care. In addition to this variable mentioned above, age at first marriage, planning of pregnancy, educational level showed statistically significant association with institutional service utilization. Now, this is the second hurdle. That is the hurdle number 2 is the availability. The availability dimension shows that number of subcentres per 100 square kilometer, the uppermost part and the lower part, that is the middle, particularly almost 30% have number of subcentres within 100 square kilometer, whereas the population per subcentre, the result is very poor in the northern and of course in the southern part. The number of health centers per 100 square kilometer also depict the same picture, that is the paucity of healthcare centers in this block. The doctor population ratio shows that 30% GPs can access the doctor population ratio, that is within 10,000 population there is 1 doctor, but 70% GPs, more than 10,000 population, almost more than 20 or more than 15,000 population, there is 1 doctor. See the availability of number of beds, always beds is not available, 62% opine that. Number of doctors not always available, 72% opine that. And of course the private hospital is not very close, and number of nurse also is not available as per the field survey in this region. The hurdle number 3 is the affordability dimension. See the affordability dimension, the mean distance for the OPD treatment to Southern Hospital and Rural Hospital close to 20 kilometers on an average. And it takes on an average almost 2 hours to avail this. Mean total expenditure amounts to almost rupees 500 to rupees 250 respectively at the HD hospital and rural hospital. The same picture is true for the IPD treatment also. In the last 30 days it has been studied, that means before March, it has been studied in February. And of course, the socioeconomic class using the wealth index, it has been found that 66% houses belongs to poor household insofar as wealth index is concerned. Monthly health expenditure of poor averaged around 450 and maternal health expenditure around 400. And of course, the poor people's source of financing having from the borrowing from relatives, selling household items and animals, and borrowing from the money lenders. What is important? It has been found that borrowing from money lenders is the last resort, since the households have no capacity to pay the high interest rates. Rather than borrowing from money lenders, they prefer to sell their articles. Insofar as the social acceptability issues is concerned, it has been found that getting permission to go to healthcare center, the family and husband sometimes poses a barrier. Another important dimension that is most important, I do think, is the availability of the female physician. The women are found to be reluctant to go to a healthcare center where there is no female physician, particularly during their pregnancy and of course after their childbirth. 66% women said that they are reluctant to go to the healthcare center because of the paucity of the female physician there. And most of them prefer for RMP clinic, that is 48% almost prefer for RMP clinic to have their primary checkup. And the time taken, that almost 36% opine that it is more than 22 hours to reach the healthcare facilities in these circumstances. Now, this is important parameters that has been from the high accessible village and low accessible village. It has been surveyed that the barriers has been classified into 3 structural barriers, bifurcated into 2, that is distance to health facilities and transportation to health facilities. Financial barriers particularly corresponds to the payment for medical services, and the cultural barriers particularly incorporates 3 items, that is allocating time to go, getting permission to go, and concerned about lack of doctor. In the high accessible areas, over 70% mature illiterate married women told that distance and transportation are the major problems to healthcare service. Illiterate and married women, including those recently married, felt financial barriers more traveling. In fact, over 50% people having average monthly income of less than 5,000 consider both distance and transportation to be a major obstacle in healthcare access. Both the lack of doctor and getting permission to go become serious problems for those women who are illiterate, aged more than 4 years, recently married, and irrespective of joint and nuclear family structure. Insofar as the low accessibility villages are concerned, it has been found the problem of healthcare access to healthcare services is vigorous in low accessible area, irrespective to women residing in either joint or nuclear family structure. Every 3 out of 4 recently married and married women face difficulty in covering the distance to healthcare services, as well as face hardship in commuting. The problems of payment for medical services are troublesome to women in general and women belonging to low-income families and recently married in particular. Want of doctor in time poses a problem to both married and recently married women, while permission to go to healthcare units is a serious issue to a married woman and those with a poor economic condition. Sometimes the family norms overshadow the accessibility and financial issues with regard to access to healthcare service. And insofar as the logistic integration model is concerned, in particular in the high accessible and low accessible areas, it has been found that 1 kilometer increase in walking distance to nearest healthcare center resulted in a reduction of odds of regular antenatal care visit by a factor of 14.70 in high accessible areas and by a factor of 0.82 in low accessible areas. Simultaneously, the time to go to healthcare center and regular ANC visit are found to be statistically significant. And it is a fact that from the study, it has been found that the area suffers from log jams of barriers pertaining to the structural barriers, financial barriers, and cultural barriers. Structural barriers like the distance and transportation to healthcare services are more pronounced in low accessible areas. Most of the area witness scanty all-weather motorable roads. Distance to hospital is substantial. Means of transportation are very limited. Women have to rely heavily on motor van, and that too is found to be irregular. The problems of payment for medical services are troublesome to women in general belonging to low-income families, both in low and high accessible villages. A large number of women depend on traditional family norms, which put a hurdle on having institutionalized facilities in case of delivery. Availability of doctor is found to be inadequate. Getting permission to go to healthcare center poses a major problem to a large number of women. And in the last scenario, in the last phase of my lecture, I will deliver that these challenges are almost there in the block level, and these challenges are almost there in the district level, and of course in West Bengal level, and of course in Indian level, in the rural areas of West Bengal or India. And what is important, the challenges of COVID added a more complicated situation. The healthcare system is not adequate to or prepared to contain the COVID-19 transmission in rural areas because of shortage of hospital beds, doctors, equipments, especially in densely populated underserved areas. Now, what is found, the country at present is at the tipping point, and we do not know what direction it will take. The outbreak can head in either way. The preventive strategies do not appear to be very innovative. It follows the strategy devised by John Hager's 18th century rules of prevention for eradicating smallpox based on 3 principles. Principle number 1, find every use, isolate the infected individuals, and immunize all the contacts. The shutdown and the ban of normal activities seeks to stop community spread. But the question is, how long? The impacts of lockdown strategy already in social sphere is multidimensional. People are, as already Professor Satpathy said, and of course, Madam Bhashoti ma'am also highlighted elaborately, that migration is a serious problem, that that people are walking back their villages in groups that we have noticed in last a couple of months ago, that covering 500 to 600 kilometers after losing their jobs in cities, which is alarming, and chance of community transmission widens further. It is a serious concern because if 1% of them are infected, we will not be able to control the spread of this epidemic due to our resource limitations that have already discussed elaborately, poor health services in rural areas. Now, in conclusion, we can say that WHO Chief Scientist, Dr. Soumya Swaminathan, has expressed concern and want that rural India may become the next coronavirus hotbed, and emphasizes the need to use this opportunity to strengthen and improve its primary healthcare system. It has been published in 31st March by Dr. Soumya Swaminathan. And it has been, although it is impossible to transform our primary healthcare system in a day or week or a month, the right step in this direction will definitely help in the future. The coming weeks and months is very challenging for us, for India, and it needs to take strong action to meet this emergency and its after effects. Otherwise, the sustainable goals, development goals, insofar as the good quality health is concerned, will stay in paper. So we have to develop our infrastructure, as well as we have to overcome the 4 hurdles, the 4A hurdles that I have already mentioned to have good quality health for the future generations and of course for the present generations. Thank you all for hearing this webinar. At last I am just also very thankful to the organizing committee and all the members of the college who was directly and indirectly involved in such an webinar, the audience, and of course our other resource persons for making the webinars as a grand success. Thank you all. Thank you.
Welcome. Thank you so much. Thank you so much, sir, Dr. Shobhan Ghosh, for your very clear view on rural health scenario. And also you have enriched us about the poor health system in rural India. You have depicted a clear map on the rural health condition. And you have mentioned so many dimensions of the rural health condition that really it is a very fantastic information we are getting from your clear presentation. And also now I'll come to the question answer session. First of all, I have to go to the Dr. Shobhan Ghosh for my personal. Are you getting my voice, sir?
Yeah, clearly.
Okay. Actually, you have studied the South 24 Parganas in my own area. I live in this area. Actually, you have mentioned so many hurdles in the rural scenario in case of the health scenario. And you have mentioned that there are so many problems in accessibility, so many, etc., and also in infrastructure of the hospital, etc. And I'm just giving an information about this subject as I live in this area. When a deliverable mother going to take the care from the institution, then in that time he will certainly think that if I take the admission to the government hospital, there is no infrastructure. And also then he will think that if I take the admission to the nursing home, then the doctors will do enforcedly cesarean delivery. So there is the 2 types of the barrier, how they will take the actual decision and where they will go. What is your own opinion in this regard?
Yeah, this is a very pertinent question and good question, Dr. Ramdev sir. It has been found from my study that yes, one problem embraces the accessibility to issue. Another problem is affordability issue. Another problem is availability issue. So it is important that in Indian context, what is found in the rural hospitals, they are there should be 5 specialized doctors. Now it has been found that it is a standard. This is a standard. But now it has been found that only one doctor is there to handle all those things. And of course, there is shortage of medical professionals. So doctor is working like a man with no army with him. So this is a very critical situation. So in this situation, I think first of all, we have to because of the financial constraints, because of the financial, we must keep in mind that it is the high time. It is high time that we have to. We have to think over that that we are already challenged, and before COVID-19, now COVID-19 has come, so it is a high time to develop infrastructure. It is high time to recruit medical professionals, medical officers, and of course the doctors, because doctor population ratio is doctor population ratio is enlarging day by day. So this is very high time. So I think that this is we have to ponder over this. We have to ponder over this. Okay. Thank you. Good question.
Thank you so much, sir. I'll come to Dr. Bhashoti Das. Are you online, ma'am? Are you getting my voice, ma'am? Madam, are you getting my voice? Dr. Bhashoti Das. There are so many questions to Dr. Bhashoti Das, but I'm not getting any connection to her. So I am just waiting, and also I'm requesting Devabrata Mondol, please connect with ma'am. There are so many questions to her. Devabrata, are you getting my voice? Hello? Devabrata, getting my voice? Is our ma'am is on our line or not? Hello?
She is well, but not.
I'm not getting your voice clearly, Devabrata. Are you getting my voice? Hello? I don't know what's happening. I'm not getting connection with you and also our ma'am. Devabrata. Okay, I will come to our ma'am, and but I try to see whether different kind of question is there or not. Only to ma'am. The participants have made so many questions, but only to our ma'am. There is no question to other resource person. And also I'm not getting any connection with her. So I'm just waiting for a while, then I'll continue. Madam, are you getting my voice?
Visible but not audible right now.
Devabrata? I think
yes, sir.
We have lost the connection.
Am I audible to you?
Yes, I'm getting your voice, but I'm not able to get the voice from our madam. So somehow we are not getting the connection with our madam. Okay, I'm continue with the today's vote of thanks. I'm coming to the main and the last session, and just I have to conclude this webinar. Okay. I'm just coming to the conclusion. I deem it a great honor and privilege to propose a vote of thanks on this memorable webinar. On behalf of the Department of Geography, Magrahat College, I would like to express my heartfelt thanks to Professor Lokhinarayan Satpathy for your memorable presentation. Not only that, this program has become so graceful because of your unstinted support and guidance. Once again, I would like to express my hearty thanks for you. I'm also very thankful to Dr. Bhashoti Das, Associate Professor, Department of Geography, Jawaharlal Nehru University, for your very informative and enlightening presentation. Thank you so much, ma'am, for your spontaneous response. I would like to extend my heartfelt thanks to Dr. Shobhan Ghosh, Associate Professor, Department of Geography, Diamond Harbour Women University, for delivering such a unique lecture. Thank you so much, sir, for your graceful and very relevant topic. I would like to thank our beloved Chief Patron, Principal of Magrahat College, for his generous support and open-handed cooperation. I also thank our Honorable GB President for his very active cooperation. I also extend my thanks to Professor Mandira Sarkar, coordinator of IQAC, for her enormous support and inaugural speech. I must thank my sister colleague Yasmin Khatun, the convener of the webinar, for her wholehearted activities. Only because of her very hard effort, this program has come into success. I must thank my brother, Devabrata Mondal. He is an active geographer. This webinar can't be organized without his open-handed cooperation. And lastly, but not least, I extend my hearty thanks for all the participants. Apart from them, this program is useless. Thank you so much. Thank you so much to all of you.
Thank you, Devobroto, for technical support of our webinar. Once again, thanks to all to present here and making a grand success.
Thank you, Yasmin. Thank you. Thank you so much. So, we're ending our webinar for today's. Thank you.
Yes.
Thank you to all of you. Devabrato.
Hello. Hello.
Ma'am, are you on line, ma'am? Are you getting my voice?
I am getting, but you are not getting.
Somehow.
Are you getting?
Yes, now
Are you
I'm getting you
getting?
clearly.
Oh my God. Oh my God.
So I don't know how many participants who have made the question. He is not there. Is present
Yeah,
or not? I don't know.
I was interested to answer them also.
So what can I do now? I don't know whether that participant is there or not.
I came down near to the router now. I was sitting upstairs.
Okay. People, are you present with us? People has made a question. I'm going to you, ma'am. Ma'am, I asked on question that how to sustainable development process large population Delhi is more polluted city, how to control pollution?
How to control pollution?
Pollution.
That is the thing I said, that inequality needs to be reduced. So decentralization of the economic activity. All the economic activities are concentrated. It is not only Delhi. Delhi has geographical disadvantage also. It is dry. It receives less rain, and wind in the summer comes from the desert area, so it receives lot of sand. And Aravalli, all of you know, has been vanished, so there is no that western boundary which was acting as barrier. So many disadvantages are there. So how to reduce is to decentralize the economic activities and as well as the social activities. There is no need to establish 5 central universities in a small city, because Delhi's role as a capital city is mostly administrative. Universities could have gone to Raipur or Malda or Samastipur. In those areas, universities could easily have been survive in those areas. That is our lopsided policy. So decentralization is the key to control pollution.
Thank you, ma'am. Thank you. One more question from Sitla P. Sharma. She made the question like this. Ma'am, I want to ask a question. In COVID pandemic, the reverse migration occurred in high level. How they are survive until the supply chain is not working properly because of insufficient supply of food chain and corruption in supply chain.
That is not immediately visible because whatever the stores were available, government has tried to maintain the supply of PDS. All of us know how those foods are being distributed and the rations amount has been increased, and also the zero balance account holder have started receiving those 500 rupees per month, 2000 rupees per quarter, and I have heard one ADB presentation yesterday where they said till November it will definitely continue that cash flow. After that, they have to review the situation so that they can even buy some food. And at the same time, reverse migration again has started reversing. People started to come back in the cities because cities are back to the track. So hope we should be hopeful. We should not be disheartened. And corruption remains our eternal fight at all level.
Okay, okay. Okay, ma'am, one more question is there. Debabrata Mondal has made this question.
Yes.
In current situation, what are the gender migration issues within India in the context of employment opportunity?
Yes. If you consider the COVID situation and gender migration, overall gender or to be very specific, migration among the women were very selective. All of us know that mobility of them are still restricted. Women folk do not go for menial job or manual job or unskilled job by themselves. They join their husband, their brothers, their father. They do not go by themselves. So whether it is pre-COVID or post-COVID, as long as it is education related migration, skill migration, attraction remains the same whether it is pre-COVID or post-COVID. If some nurse wants to join the Calcutta hospital, she can join from anywhere.
It's fact.
Her scope is not reduced. So women are mostly still the skilled migration or otherwise associational migration. So they are not that much hard. The amount the male migrants have been hurt by this.
Okay, okay, ma'am. This is the last question. This question made by the Sonjila Thapa. She is telling India has one of the largest slums area in Asia. The question is how these slums are tackling to COVID to their daily to sustain.
How they are tackling, if you
how these slums are tackling to COVID to their
tackling this
daily
COVID
to sustain.
Daily means daily
life, I think.
Daily life, yes. She is asking daily life, how they are leading to sustain in this COVID pandemic. I think
exactly
this
so,
is
I
the
think.
question.
Yes, yes.
So if it is so, all the slums are very unique in nature, and every state has their own way to tackling it. I can tell you about Delhi, where a lot of NGOs are working by supplying them the soap kit and the sanitizer kit, and the slum dwellers where they are working, you have to accept that slum dwellers cannot afford to remain idle. So all of them are working, all adult population, they are working, and wherever they are working, একটু একটা ইয়ে আসছে, কারোর একটা আনমিউট আছে, সেই কথাটা আসছে। তো whoever is working, they are also providing them the sanitizer as well as soaps and the mask. Because I am in a residential university, I can see how the sanitation workers, mess workers, and other maintenance worker of the hostels are working. We are supplying them hand gloves, masks, sanitizer, all these things for their work, because their safety is also related with our safety. Our safety is related with their safety. So that's how they are doing. And of course, what I see, the all the sanitation workers were thoroughly active. They did not have any lockdown. Even with the academicians enjoyed some lockdown, so they are maintaining the cleanliness and the other thing. Some
Exactly.
uh,
Thank you so much. This is our
Thank
question
you.
to you.
Okay,
Thank
okay.
you.
Thank you.
Thank you.
Thank you. Finally, I could talk.
Yes,
Otherwise, we are
yes.
all.
And this is the technological hazard. You have to
Ha,
clear
ha,
it.
ha,
This is the
ha,
main problem
ha,
of this webinar.
ha.
And
No, no. Even in the seminar, mic goes off many times.
it's true.
So technology, as long as there, we have to live with this.
It's
Okay.
true. It's
Ha.
true. Thank you so much, ma'am.
We'll be
We are
habituated.
very happy. We are
Thank
very
you.
happy to get you.
Thank you. Thank you.
Thank you.
Thank you.
Oh, this is the last session. We have to conclude our session. And I have already proposed the vote of thanks also. And lastly, I will mention I must thank my brother Devbrata Mondal. He is an active geographer. This webinar can't be organized without his open-handed cooperation. And lastly, but not least, I extend my hearty thanks for all the participants. Apart from them, this program is useless. Thank you. Thank you so much. Thank you so much to all of you.
Thank you.